we'll be having a panel discussion for an hour's time where it is going to be a knowledge bomb again. We have all set of faculties who are going to discuss practical things about patient safety challenges during transfer, which is very, very, kind of a neglected area, I would say. Probably we're trying to transfer a patient and we don't try to pay attention towards it, right? So to have this, first I would request, and I take this privilege of welcoming our moderator, Dr. T.S. Srinath Kumar, sir, who is our moderator for this particular panel discussion. And sir is Senior Consultant and Group Head, Department of Emergency Medicine, Sparsh Hospitals, Bangalore. And he's also an Academic Council Chair for SEMI. So along with Dr. Srinath, I would also take this privilege of introducing three other faculties who will be joining us. One is Dr. Venkat Kotamraju. Sir is the consultant from Royal Derby Hospitals, United Kingdom. And we also have two other faculties who will be joining us. Dr. Praneeth, who is a consultant, emergency medicine at Apollo Hospitals, Hyderabad. He's also Joint Secretary, SEMI, Telangana chapter. And sir is also clinical lead for trauma centers under Apollo Hospitals, Hyderabad. And the last but not the least, we have one more eminent speaker, who is Manickavasagam. He's head of academic advanced paramedic and academics and AHS, Dr. Mehta's Hospital, Chennai, and he's also GC member, quality professional, and representative of paramedics at CAHO. He is also a technical committee member, QI, accreditation for medical transport organizations and ambulances. So we are having a very beautiful panel. Along with them, we will also have our eminent speakers who have already spoken to us, Dr. Shaik Manzoor Eilahi, Dr. Priyanka MK, Dr. Khusrav Bhajan, and Dr. Naga Nischal. So, and Dr. Sudeshna Ganguly too. So we'll have all these eminent speakers to speak about and discuss on patient safety challenges during transfers. Over to you, Srinath, sir.
Yeah, good evening, everybody. It's a pleasure to meet you all, everybody. Thank you for this opportunity, Kaho, and thank you to our president, Dr. Kumar, who has been spearheading on the quality. So, to start with the panel discussion, will be on patient safety challenges during the transfers, and it's all important that we all know how important when we monitor the patient, do the right treatment. I always keep telling to my residents and everybody that there are 3 R's which are very important. One is the right hospital by the right treatment for the right care of the patient. So the triple R, what we see, is the most important here. To start with, the first question is to Dr. Khusrav Bhajan. So I think it's visible. What are the most common patient risk associated with transferring a patient from the ED to the inpatient units?
Yeah, thanks, Srinath. Yeah. So I would quote Winston Churchill here, who said, failing to prepare is preparing to fail. And therefore, we must be very prepared to transport a patient out of the ED to either the CAT scanner, the MRI, the ICU, or the OR, which are the common places to do. I would just list in division. I would divide these most common patient risk factors into communication problems, patient-related problems, and then equipment and monitoring problems. And I'll just take a minute or two to decide this. In communication, we need to talk to the receiving area like the ICU, whether the bed is completely available, or the OR, whether the patient is ready to be taken in and wheeled into the OR, or the CAT scanner or the MRI where there is no other patient already in, and we should not be wasting time or delay in the diagnostics here or the transfer of the patient elsewhere. I mean, to the designed or dedicated area. We also should take a good communication into account of taking a good history of any metal objects before sending them to the MRI, whether it's compatible or not. And we need to understand that we need to talk to the relatives about the payments, about the cost, about the risks and the benefits of the particular procedure or the treatment. Coming to the patient, always remember that we may do a very good deal in patient safety and manage the patient well in the ER, but when we transport them, then all the problems occur. And thanks for this panel, because it's very important for us to note. A patient may have a cardiac arrest and a defibrillator battery may not be working, or the patient needs intubation and the Glasgow coma scale has worsened, or the patient becomes delirious and has a fall from the trolley, or the patient becomes hypotensive. So we need to prepare for all these things. Another usual trend is the junior most person who joins duty is sent for a transport, which is absolutely ridiculous, because we need a reasonably well-trained senior person to accompany. So the patient and personnel related things can be avoided. Also, there will be infection control breach in these patients, because in a rush, in an emergency, when you are out of your own department, you are not so confident. So you may not remember to wear gloves, gowns, etc. And there will be a breach in the infection control. As regards the equipment and the monitoring, there can be malfunctioning. The battery may not work. There may not be a backup. There could be dislodgement of the lines and tubes, and that could be a disaster there. And sometimes patient goes into the MRI and you don't have long cables to actually monitor them, and you might lose the patient in the MRI. So choose your area of diagnostics or the actual endpoint of transfer of these patients. And I would say one sentence here, that do it safely, but rather than shifting a patient or transporting a patient from the ER to wherever, transport the entire ER with the patient. So you should have all equipment, all personnel that you have in the ER available during the transport.
Thank you, Dr. Khusrav. As usual, it's been the right way to answer and the right path for all the personnel who are listening to this particular program on the quality standards and the quality safety. We'll move on to the next question. Can I have the next slide, please? So the next question is to Dr. Manzoor, Sheikh Manzoor Eilahi. It's about how do communication breakdowns between the ED and the reviving units impact patient safety during the transfers. Dr. Manzoor, you're there?
Good evening, sir. Thank you. Very kind of you to, weave a question around communication, which is very much related to my talk this evening, makes my job easier. So again, communication breakdowns and communication, in any of the speakers, if you have observed in some way or the other, they mention communication is important. You have to give due importance to communication. Khusrav sir himself said you need to have a good communication. When you're shifting for a MRI, you need to ensure that patient is not having any metal implant or any metal on them. So communication indeed is very important. And communication breakdowns and how to mitigate them is even more important, because right from the time we get a out call, when somebody calls for a help or a EMS service, pre-hospital care, or an ambulance, we have to get their demographic data right. We have to get the what is the reason why they have called them, what is a medical emergency, is it a surgical emergency, where are they, how far are they, what are the different resources that we need to take along with us, do they have an elevator, do they live on a 10th floor and the elevator does not work, and this is fatal to go there and realize that they are on the 10th floor and they don't have an elevator. But if we have the resources, if we have the preparation, we'll be able to overcome this difficulty, right? So right from that point, we need to have the proper communication. And while pick up also, when you are picking up the patient from a different healthcare facility or picking up the patient from home, we need to be very careful. For example, in a toxicology victim, in a poisoning victim, the scene at the pre-hospital scene, how it is, gives a lot of clues about and lot of insights about how to treat the patient. Are there any pills, empty pills, is the room shabby, how is the locality, all this gives us a lot of important data. And we are transferring a patient from a different healthcare facility, It's very important to have the relevant medical records which will help us in treating the patient. There is no point in traveling probably 45 minutes or an hour and a half and shifting the patient to your medical facility and realizing that all the critical important medical records which were required to take some life-saving interventions and decisions for this patient we have not collected along with us. So that is again difficult, and it does not end there. Even after the transfer, once you have handed over the patient in the emergency, again, what sort of documentation have you maintained? What has happened during the transfer? Have you given any medications during the transfer? Have any interventions being done during the transfer? So we need a sort of a small summary or a record of what has happened during transit. So two sets of vitals are again very important before transfer and after transfer, and especially in a moving ambulance with the siren on, with the ambient noise of the traffic, how we are going to effectively communicate. Are we going to use a cell phone? Are we going to use any other different form of communication? What if the cell phone battery runs out? What if there is no signal? How do we overcome this, right? So AI and technology are now coming in. 5G ambulances are coming in. We are seeing a lot of health tech in the realm of EMS and pre-hospital care, where solutions are being developed to overcome these kind of communication backgrounds. They are upcoming. We have not seen them at a mass scale, but sooner than later, we will see some good practices in terms of technology, which will help us overcome these communication breakdowns. Thank you, sir.
Thanks, Manzoor, for that comprehensive answer. When the communication breakdowns happens and what kind of effect to the quality will be coming down, we all know that it's important to communicate to the patient attenders, and also to the receiving hospitals. All these put together only will have the right care for the patient. We move on to the next question. The next question is, what challenges arise in maintaining continuity of care during the transition from the ED? By Manickavasagam. He is the right person to answer this.
Yeah, thank you, sir. So during the transportation, there are a lot of errors will be happen due to the wrong decision and due to communication errors, as we discussed earlier also by the another faculties. So better we can avoid that errors by taking a right decision of after stabilization, we can initiate the transfer. It will be the better option, and then proper communication to the EMS team with the verbal and written communication and pre-dispatch checking the ambulance might be helpful to continuity of care without interrupting any errors, any care due to the equipment failures. So after the transfer in the en route, we need to secure the patient safely in the stretcher with the proper straps, and then continue monitoring without any interruptions, and then take we need to avoid many procedures in the ambulance. That's the reason why we need to stabilize, and then whatever we need to take up procedure, we can initiate in the emergency itself before transfer. During the transfer, just we need to take care of monitoring, and then if needed any emergency resuscitation, we can initiate. That will helpful to continuity of care, and then all the equipments availability to be checked before, because that sometimes that equipment will not be work. Sometimes that in route the additional medications may need to start initiate. So we need to take adequate equipments and additional medications. Everything will minimize the errors during the transfers. And also the handover to the another ED with the proper treatment history of the entire treatment history and expected management in the another hospital. Everything we need to submit along with the investigation reports. It will improve the continuity of care in the new facility.
Thank you, Manikam. So that was a good comprehensive answer, because you're the person who handles all these things, and your team is excellent doing this work past so many years now. Thank you for that, highlighting all the answers. So now moving on to the next question. How does the time of day, that is example, a night shift, weekends, affect the safety of the patient transfers from the emergency department? and it's none other than by Dr. Priyanka MK.
Thank you, sir, for that. I think time of the day severely or significantly impacts safety of patient transfers. So the most important being the evening shifts and the night shifts. So staffing levels, fatigue among doctors and staff, and transfers during night late hours when they're usually the staff are tired, they're fatigued. It can increase the risk of errors. Also, night shifts often have fewer senior staff, and the cumulative fatigue of junior staff with increased load of patient may lead to lapses in judgment. There can be slower response times. Also, availability of resources. So many centers may not have certain diagnostic services or specialist consultations, and even transport options may be limited in off hours. And this can lead to decisions made with incomplete information. And again, it can impact patient safety. Handover quality again. The handover quality of a night shift doctor to morning, morning to afternoon, afternoon to night again. There you can actually visibly see the differences. And those who are leaving from morning to afternoon, usually it's a proper clinical handover. But those who are going from evening to night or night to morning, there is rushed handover or incomplete handover, causing a lot of miscommunication and subsequent errors. Also, patient's clinical condition. If you shift a patient in the night, then those who are acutely ill or deteriorating with inadequate resources, and also the emergency response team may not be fully staffed in the night, and there may be significant delay in addressing life-threatening issues. Also, in the night, the hospital is kind of very quiet. So it means there are fewer eyes on the patient, fewer people able to notice and respond to problems quickly. And there has been significant research which shows that transfers during off-peak hours, that is night and holidays, cause higher risk of adverse effects because of all this. So that would be it. Thank you.
Thanks for the answer. That's good on Priyanka, because that is the most important thing, the weekends and the night shifts, where we all are aware how it can affect the patient. But maintaining the same standards, what we do the week long, will not affect the patient care. That's the right answer. Thank you very much, Dr. Priyanka. Moving on to the next question. The next question is, how can hospitals reduce delays in transferring patients from the emergency department to inpatient units, and what impact do these delays have on patient safety? May I ask Dr. Praneeth Oladri to answer this question, please?
Hello, sir. Thanks for your opportunity. And first of all, let me break this question into two components. That is how delays in emergency department causes patient safety issues. And second thing, how we can avoid these delays. So first thing, when the patient's shifting gets delayed, this has three different impacts. First thing is the perception of the patient and patient attendance, which can intimidate the staff and also the doctor in the hospital, doctor who is attending the patient. And this can make this can erupt into a continuous lineage of questions to the doctor, saying what is happening, what you're doing, what is going to happen in next few hours, what you have done all these days, all these 1 to 2 hours. Like these questions can come. And second thing is, as emergency is an environment where there is no limit for the number of patients which can come in. Whereas once a patient gets shifted to ICU or ward, there is limited number of beds or limited number of possible number of patients per possible number of nurses or doctors. So the continuity of care or the monitoring of the patient is superior over there. But whereas in emergency room, what happens is, if there is one more cardiac arrest coming, or if there are 2 trauma patients who have come in right away, then immediately the monitoring of these patients comes down, because almost all the staff had gone there to stabilize these patients. So this is going to impact the monitoring of the patient who is waiting in the ED for longer hours, and that is going to have if the patient is having any deterioration, then identifying this deterioration will get more and more delayed. So how we can avoid these kind of delays? So usually these delays will occur because of, first thing is investigations. So probably we might have sent some investigations, we are waiting for those results, like troponin I. So till the troponin I comes, we cannot make any decision on the patient. And second thing is bed availability in the hospital. So if beds are not available in the hospital, or it is taking time for the hospital to make these beds available, then we should be waiting. And sometimes, even though all these things are sorted, the teamwork, that is when, if we wanted to shift a patient, that is not just one person's work, or not just a doctor, not just a nurse. It is the receiving team and the sending team and the people who are transferring the patient. And during the transfer, if any other new patient comes, all these things are going to affect. So how we can cope up with all these things is when we plan the things properly. So as soon as a patient comes, immediately, if we are able to plan, okay, we might need these investigations, we might have to do these things. And if we involve the specialist teams at the earliest, these delays can be cut down. And when we use non-clinical staff well, then we can shift the patients immediately or as early as possible. Like admissions team or housekeeping team or receiving team, these people can help us to shift these patients fast. Thank you, sir.
Thanks, Praneeth, for that comprehensive answer. Inter-hospital transfers or inpatient transfers, and Praneeth is from the hospital where he works and looks into more of pre-hospital management and takes care of this one. It's very nice to hear from you. Moving on to the next question. Yeah. So the next question is, what is the role of handoff protocols for enhancing the patient safety during transfers from the emergency department? Can I ask Dr. Priyanka MK to please pitch in for this answer?
Thank you, sir. So like I said, during shift transfers and time of the day, handoff protocols are extremely important, mainly for ensuring continuity of care. You need to hand over any patient who's present with you till the patient is physically discharged from ER. It's not just a system discharge or a financial discharge. So most of the time we get a handover saying patient is for discharge, waiting for the bill, but the patient is physically still there with you in the ER. So till the patient physically leaves the emergency room, you're responsible for the patient. So standardized communication. So there are a lot of algorithms available like S-bar, there is iPass. So all these can reduce the risk of omission or misunderstanding or miscommunication. So handover basically ensures there is continuity in the care. There's reduction of error, like medication administration, missed follow-up of tests, failure to recognize deterioration of patient's condition, or even improvement of patient's condition. So there are a lot of error reduction, which can be done by proper structured handover. Third important thing is accountability. So handover gives you a very, very important verification step. So the receiving provider confirms the information. And if they have any uncertainties, they can get it clarified. Usually a handed over a patient is given a stepmotherly treatment. You'd prefer to see and treat your own patients, but handed over patients are usually neglected. So a simple thing like going back and asking them or talking to them, asking them what was the problem, why they're still waiting, is there anything we can do, can really improve patient care, and they get a lot of immense satisfaction in talking. The second important thing is introducing the handed over doctor. So if you are handing over a patient to another doctor, it's not important to only write in the system about handover notes, I'm handing over from this to that. It's important to go and talk to the patient and the attender and tell them that, look, my shift is over. I'm handing you will be taken care of by this doctor. So that again is a very, very important thing in accountability and continuing care. Third is documentation and traceability. So any handoff protocol, anything happens in change in care or anything, so that can be really taken care of by a structured, written and documented handover. And at the end of the day, all of us are looking at patient-centered care and patient satisfaction. So I think handing over plays very crucial role, especially in the emergency department. Thank you, sir.
Thank you, Dr. Priyanka. As you rightly mentioned about not only about the patient handover and the doctor handover in front of the patient, that lies the key. And that has a much role, what I feel, because when you stand in front of the patient and the doctor whom you're handing over, the patient will also know, and you will also not forget what you have done for the patient. That is very important, because you would have done 100 good things. If it has not been handed over, then whatever we do, it's not been carried forward. Thank you very much, Dr. Priyanka, for that answer. Moving on to the next question. Next question, can I ask Dr. Khusrav Bhajan, how can interdisciplinary collaboration be improved to enhance patient safety during the transfers from the emergency department?
Yeah, thanks, Shri, for that question. I definitely feel that a very good communication between the interdisciplinary approach would be very important. So if we have three things where we would be shifting our patient, that would be radiology, which is CT or MR, or ICU or OT. And therefore, we need to have a improved communication system between the sending unit, which is our ER, and the receiving unit, which could be any one of these three mentioned. It's extremely important to also know that the beds are available. It is ready. They are ready to take our patient, and there is no delay in transport. Secondly, we should be very clear that what all we have done should be documented, and what needs to be done should be a plan required for the ICU for continuum of care. So I think a continuous monitoring support system and a continuous protocol-based approach would be very good. Secondly, whenever we transfer a patient, I may have, as mentioned by Priyanka again, there may be a shift change and a handover may have happened appropriately, but it's seen by Dr. A, and then we just call upon Dr. B to transfer this patient. And that could be a mess because that patient, that doctor does not know the patient so well. Sometimes if they are asked by the ICU, have you put in a central line, etc., or a Foley's, they may actually lift up the blanket to try and find out. So this is very, very embarrassing and not appropriate, and it can be a high risk for patient outcome. Also, what we do is whenever there are critical patients going to the ICU, after being monitored and stabilized in the ER, we call upon the ICU doctor on duty to come down to the ER, and we together discuss the further plan. We tell them what we have done, and then the ICU person writes their plan, and we have a interdisciplinary communication, which is excellent, and that seems to be working for my unit and my hospital. I also feel that we can do some common training programs just to improve the brotherhood or the coordination between the two teams, and we can have topics where we can do emergency and critical care together and have all the residents come across once in a while, not all the time. So I think this is very important. And if you can have a very good communication and a comprehensive handover, then most of the problems with transfer can be mitigated.
Thank you, Dr. Khusrav, for that answer. That's a nice way, and what is required at that particular moment. So, moving on to the next question, can I ask Dr. Naga Nischal to answer this one? What are the specific safety concerns when transferring patients with complex medical histories from the emergency department? It's a right question for Dr. Nischal because he's been in the in the emergency past 16, 17 years, and he's been handling the pediatric and obstetric emergencies currently. So, Dr. Nischal, please answer.
Great. Thanks, Dr. Srinath. I think when you're dealing with complex medical histories, all the golden rules, what Dr. Khusrav said and Dr. Priyanka said, hold good. The most important thing here is to ensure the information is not lost. When you have a complex case, you have a long history, whether diabetic, hypertension, allergies, CTVS, CABG, ECMO. So when you have too many things, you tend to miss one or the other. So first and foremost, you should ensure there is no loss of information, which is in the right way what was discussed, to have a standard handover protocol. Document all your information, whether you're transferring this patient inside your hospital or you're transferring this patient outside. Ensure the information is not lost. Paper, digital, reiteration verbally again to the receiving team. That I think information is the most important. Second is the biggest challenge with safety is also when you're handling a monitor, handling a ventilated patient, handling oxygen cylinder, and let's say you're handling an ECMO patient. So when you're transferring, you need to have one person just look at, is everything in place? Is all the tubes connected? And you need to have something very similar to what you do in OT, right? Sign in, time out. More often while we transfer such patients, you get to know that one tube got disconnected because while you checked all the 10, the 11th one was missed. So sign in timeout process before you move the bed out of your ER ensures all the nuts and bolts are there and you don't have any loose ends of your tubes hanging as you start moving the patient. Of course, the infra plays a huge role. You need to have something which is ergonomically easy. You can't have the nurse hold one cylinder and pull the bed also. So the safety issues, especially with complexly, medical sick patients, is you need to have the right infra. You need to ensure the information is not lost. And of course, training all your staff, not just the people who are transferring, but also the patients or the people who are receiving this patient. So this, in a nutshell, should ensure the patient transfer is safe and done rightly.
Thank you, Dr. Nischal. Handling the complex patients during the medical transfers is again a mystery, and the mystery is always when you're carrying the patient from one place to another, you are the best person to note and you are the best person to treat and take care of the patient. Moving on to the next question. Can I ask all the panelists, how does the transfer of a patient from the ED to external facility, that is, example, long-term care, rehabilitation centers, pose unique safety challenges? It's open to any of the panelists.
I think the first challenge is the when you have a external facility. First is the not an apple to apple comparison, whether on a knowledge base or an infra base. So first, you're two different teams. You don't have cohesiveness. Second, you're two different facilities on both infra and knowledge. So I think what is most important here is to have a robust system where there is a check and balance, information, and also to give more time to the receiving team um, on ensuring the patient transfer is safe. You need to bridge the gap of knowledge and the team cohesiveness.
I think the second thing would be about the continuity in care. The doctor who has handed over the patient to ER, if there's any information which is not left out, then getting the rehab center or long-term care center to get back to what happened in the ER at that time would be very difficult. So to have again, there should be a structured handoff. There should be a proper discharge process, probably a sign off or a contact number of the person who's handing over to an external facility so that there can be, further communication in terms of care, which has to be continued by that rehab center or long-term care facility.
I feel transfer of a patient to another facility could be because of upscaling the treatment. Sometimes your center may not have certain equipments and doctors, and therefore you might be shifting, or you might also receive someone like that. Or then long-term care facilities, rehabilitation facilities. So I think it's very much transport here. Inter hospital transfers would probably be very much like the triage situation we do in trauma. So you try to assess the place where the patient is going, know the facilities, know the doctors, communicate with them, and also know the needs of the patient that would be inculcated once the patient is transferred. So I think it's very important to triage again. It is almost like a reverse triage where you are triaging the patient, trying to find out the needs, and then also matching it with the facility which the patient desires to go to, or we are sending for other specialized care or rehabilitation, etc.
If
Thank
I
you.
might
Thank
put
you.
in a, oh,
Yeah,
uh,
please go ahead, Sudeshna.
yeah, thank you. If I can put in, about a study which I was reading. This was done at a center in Taiwan between the years 2018 and 20. And they compared something very interesting. They compared two cohorts of adult patients who were being admitted for non-trauma conditions. And one cohort were those who had intra-hospital transfers, something I think we've been focusing on for so long, transfer from ER to somewhere within the hospital. And the other group was inter-facility transfer or inter-hospital transfer, or IHT. This is what I think this question poses on very clearly. And it was found that those patients who hit the ER or hit in a facility through this inter-hospital transfer, or IHT patients, had an increased length of stay, and also they had an overall higher death rate. So this, I think, underscores the fact that safety of patients during transfers to external facilities cannot be overemphasized, and they definitely pose some unique challenges. And it is time that we look at certain parameters which will give us an idea of whether we are doing things correctly in terms of what's the outcome of patients who are transferred to any other facility. It can be a hospice, it can be a rehab center, which are of course different. But if we are simply transferring to another hospital for whatever reason, then it's important to understand that what is the outcome of a patient who has been transferred from one hospital to another vis-a-vis a patient who is not. So I think definitely, there are some very unique challenges, and there would be more, understanding or a deeper understanding is needed on this issue. So just wanted to, highlight that point.
Thank you, all the panelists. We'll move on to the next question. Is there any questions posted from the participants?
No.
No. Okay, we'll move on to the next question.
Dr. Srinath, sorry, there is one question.
Yeah.
So what KPIs are used to assess the effectiveness of communication and handovers between ED and other departments? It's one of the questions which I raised.
Okay. And also there is, what KPIs can be used related to inter-department transfers or discharge processes to improve coordination of care? So can anyone of you want to answer this?
Dr. Priyanka took a very nice talk on KPIs, so maybe she can take this better.
So I'd probably give a spin on this before Dr. Priyanka probably steps in. So KPIs have to be measurable, right? They have to be objective. We cannot have any subjective parameters. And sometimes we can measure something directly and sometimes indirectly, right? So when you are talking about effectiveness of communication between ED and other departments, so definitely the IPASS tool we can use. But how effective is your IPASS tool probably will depend upon how many incidents we are having. We have to have an objective measure of how many errors have happened. So we have to divide these into parameters. What kind of mistake has happened? Is it medication in the hand of? What kind of error has happened? Is it in the medication? Has the same medication been given twice? Or has any investigation been repeated? Has any investigation been missed out? So we need to, so for your center, what are the KPIs you are chasing? You have to choose them, and you have to see with this tool over a period of 60 days, 90 days, what is the effectiveness of this communication and how many errors have been reported by the other department when they have taken handovers for you. So this is a indirect measure of how you can measure the effectiveness of the communication which you are having between the ED and the other departments, in particularly in the domain of the handovers.
If you're looking at KPIs, I would say you can create a KPI for handover completion rate. You can look for like what Dr. Manzoor said, error rate post handover. Then you can look at the quality of the documentation, and then knowledge transfer after handover time, and continuity of care post handover. When you're looking for interdepartmental transfer discharge process, you can say how long it takes for the patient after the doctor decides that the patient can be moved, that the patient actually moves to the ward. And then you can also look at patient satisfaction with the discharge process, discharge documentation accuracy, discharge documentation compliance. So like I said, you can make a lot of KPIs, but how much is actually going to be relevant and how much are you going to enforce and how much are you going to really go back upon? It's very easy to make a KPI, but following it is another Herculean task.
So for me, there are three main KPIs for the transport. One is if the patient has deteriorated and needed intubation or CPR or the work. So whether our assessment of transport at that moment was correct or not. These are all clinical. Whether there was a delay in the transport, whether the patient had to be kept waiting outside the CT scanner or the lift was not kept ready. And the third would be whether there was any equipment failure or line dislodgement or tube dislodgement. So I think beyond all, which are beautifully pointed out, you can keep small KPIs in terms of clinical outcome during the transport.
Thank you. Thank you.
Your ER LOS, the length of stay. Did I interrupt anyone? I'm so sorry if I did.
No. You can go ahead.
Oh, okay. Thank you. It's just that, the ER LOS, that's an overarching, KPI. See how long your patients are staying in the ER and have some benchmarks for yourself. KPIs are not prescriptive. You need to look at your demographics, your specific ER search periods, and you need to understand that what kind of a structure of patients hit your ER. Are you a stroke-specific ER? Are you an ER which sees a lot of MI? Are you an ER which sees a lot of trauma? All your KPIs would differ according to what's the largest number of patients that you see in your emergency department. First and foremost, as a very basic thing, start with the length of stay in the ER, your handover times. How much time does it take for you to make referrals out of ERs? So before we go into, making KPIs which are difficult to track, I perfectly agree with Dr. Priyanka when she says that you can have a KPI, you can have a numerator and denominator you place there. Your actual tracking of it and utilizing the data that you get from it to implement change is a colossal task that eventually often does not reach. So I would just suggest that start with the length of stay. Determine the length of stay for each particular patient group that hits your hospital. See how you fare out in terms of, in comparison with, say, international benchmarks. That would be a good starting point.
Sudeshna, that would apply to the ER, but not for the transport. So it's a good benchmark, good KPI, but whilst we are discussing transport, maybe this is not very...
Indirectly, yes, because if your transports are getting delayed, means your length of stay in the ER is longer.
Yeah.
So when you track, that is for ERs, which are starting. Of course, given the ER that you are possibly functioning at, you wouldn't look at this. You would be having more refined KPIs to look at. I'm absolutely 100% sure of that. But when you are starting with a KPI, look at your LOS and see how it reflects on your length of stay of the patient. It can be very effective to understand that whether you've transferred out at all or not. The transfer would apply when you really have, the space in your inpatient department to get your patient out.
Thank you, Dr. Sudeshna. Thank you, Dr. Khusrav, Priyanka, Manzoor, everybody for pitching in. Hope the answer was there for your question. Moving on to, there is one more question. Is screening for infectious diseases required for patients coming to ER? Should it be a part of initial assessment, and who should do it, nursing staff or ER doctors? I think absolutely this should be done as part of the initial assessment, because now both NABH as well as any accreditation panels say that it is a required part, and it should be included in the initial assessment, and it should be done initially by the nursing staff and confirmed by the ER doctors. That's what is the answer. Moving on to the next question. May I request Dr. Naga Nischal again regarding the risk associated with the transfer of the pediatric patients, because again he's holding a big responsibility in the large chain of hospitals which is responsible for mother and child. Can I request Dr. Naga Nischal to answer this question, please?
Yes. So I think the first and foremost with any pediatric patient or a specific subset of patient is to have the appropriate people doing these transfers. I think most of our doctors or our nurses get worried the moment they see a pediatric patient. So first and foremost, to is to have the appropriate people, well-trained, who are comfortable handling this. The risk of transfers is you're out of your comfort zone. You're sitting in an ambulance out of nowhere, and you should know what you need to do a step 1, 2, and 3 in a moving ambulance. So having the right person solves most of the problems. The second most important thing is to have pediatric specific things, as simple as a NG tube, as simple as a suction, as simple as a mask. So not all ambulances will fit in to transfer your pediatric patients. Have the right people, have the right things that are needed to give care, and importantly, have the right process to assess, maintain, and also hand over pediatric patients. While we never ask what's the weight in an adult patient, you certainly need to ask for a weight of the patient. And you have, with every pediatric patient, you will have 2 attachments. In the nice way I say, is your parents. So you're literally dealing with 3 patients as you're taking care of patients, especially pediatric. So these are the 3 key things that you need to keep in mind.
Thank you, Dr. Nischal. Can I move on to the next question, please? So the next question, how do resource limitations, example, staffing, equipment, impact patient safety during ED transfers? May I ask Dr. Sudeshna Ganguly, who is also an ED physician and an administrator, who is taking care of such quality work in our hospital. Can I ask Dr. Sudeshna to answer this question?
Thank you so much, sir.
May I request Dr. Sudeshna to be a little quick, please, because we are running short of time.
Okay, you
Yeah.
reserve that remark for me. I don't blame you because I'm the one who overshot time during presentation. Right. So thank you, sir, for directing this question to me. Definitely, it's a very intuitive question. And needless to say that resource limitations impact every single aspect of ED care, and patient safety during ED transfer is not an exception. I think my talk was also about a little bit, I had spoken about, how we have demand supply mismatches. Now, demand supply mismatches are not just limited to MCIs or disasters or outbreaks. They can happen at any time during ED surges also. As ER physicians, we know that there will be certain periods of time when there are surges in the ER. And that's the time when we really need to empty out beds in the emergency, and we need to transfer patients out to other areas of the hospital. And also at the same time, we need transfers to, say, OR or to radiology or to wherever the patient needs to go. So definitely we need to do some resource planning. We need to look at the overall, surge capacity of the emergency, the times when there are more transfers or more patients coming in, the times when we will need more equipment or staffing for these transfers to happen. So it has definitely a very big impact on patient safety. We need to have the right kind of staff accompanying the patient. For instance, if I have a patient who is unstable, or maybe a patient who's ventilated and being transferred to the critical care unit, I would definitely want a doctor to be accompanying that patient, in addition to other staff. Now, if I have a shortage, I need a resource in the emergency. As someone, I think, very effectively said, that we often assign the youngest team member for transfers, which again has an impact on the safety of the patient. And this leads to resource limitations again, especially when we are overwhelmed with patients. We would invariably send maybe the junior most doctor for accompanying the patient, which does not work. So it is very important to plan this out. What kind of equipments are needed for transfers? Where are our transfer ventilators? Who are the doctors who would be responsible for overseeing the transfers on that particular day? So I think a little bit of preparedness goes in here. So definitely I agree that resource limitation will impact safety during ED transfers. Transfer itself is not a very safe process, because till the patient is out of the ER and not reached the other unit where he or she needs to be, there is always a chance of equipment failure. There is always a chance of the staff not being able to take the necessary action, getting stuck in lifts, elevators, all kinds of situations and scenarios can arise. So I think in order to overcome the day-to-day resource limitations that we face, we need to plan properly, given the demographics of the particular ER where we are working in.
Thank you, Dr. Sudeshna. That was a comprehensive answer pertaining to the question. It's very nice to hear from you. There is a question from one of the members, participants. Can AI help in remote monitoring while transferring patients to the ED? Yes, that's what it's been said. The importance of 5G ambulance, what Manickavasagam was telling about the 5G ambulance or the tele services in the ambulance, and also some of the ambulance services have even put a Zoom link into the having a tab inside the ambulance and having a Zoom link which will facilitate for the transfers. These are all multiple AI equipment. There are multiple AI companies also which have come in pitched into our country and seeing that how best, because we know the traffic situation in our metro cities, how long it takes, especially let it be in Bangalore, Hyderabad, or Chennai, or Mumbai, Delhi, Calcutta, Ahmedabad. These are all the places where it is becoming a challenge for shifting of a patient. Even a 5 kilometers transfer will take at least 40 to 45 minutes. So that is the biggest challenge now, and that is how AI has helped bringing in a lot of changes into the patient transfers. Hope I have answered to your question. Moving on to the next question, I would like to request Dr. Praneeth to answer this one. What role does patient and family communication plays in ensuring safe transfers from the emergency department? I request Praneeth to keep his answer in a brief one.
Thank you for the question, sir. So, in emergency department, while handling any patients, communication plays a very important role for not just the patient satisfaction, but also to manage the patient appropriately and patient attendance appropriately. But during the transfers, this becomes more and more important. So when we appropriately communicate to the patient's family about why we are shifting, where we are shifting, what all needs we need, then this can reduce the anxiety and stress among the patients and patient families. And this enhances the patient's advocacy. And this builds the trust and collaboration between the patient and doctor or the treating facility. And when we share all these things, this becomes a shared responsibility between medical team and the family. So this helps in safe transfer of the patient. Adequate communication helps in safe transfer of the patient. Thank you, sir.
Thank you very much, Praneeth. That's important. That, as I mentioned in my first this one line, the communication plays a very important role, especially for the patient and the patient family, because they are in the peak emotions, and we as emergency physicians are very, very importantly playing role not only regarding the patient care. We have to inform to the patient attender, to the consultants, to the EMS personnel, to the administrators, keeping the timelines important, as everybody mentioned in their questions and answers. This will be the last one, I suppose, because we are moving ahead of the time. So may I ask Dr. Khusrav Bhajan to please answer this question? How can technology, example, electronic health records with transfer checklists, be leveraged to improve the patient safety during transfers from the emergency department?
Yeah, Srinath, I'll be very, very brief here. So there is
Thank
no
you, thank you.
overemphasis. Can you hear me? Yeah. So there cannot be an overemphasis on keeping a good checklist, whether it is on documentation on paper, or it can be digitalized, and you can carry your laptop or a small tablet and you can do all the checklists possible, which is a continuum of care. As regards electronic health records, it's very, very important, and it's almost always, most of the hospitals have that. It additionally helps you for real-time access of reports, of many other things. It also has automated alerts and reminders. It has an auto documentation mode, and the patient's absolute discussion and events can be tracked by using an electronic record system. When we talk of technology, you've already answered that, but the artificial intelligence is the new technology or the new kid on the block. And besides being useful, the pre-hospital scenario, it is extremely helpful in providing quality and efficiency to the patient care, improving continuum of patient care, streamlining experience of the patient, and giving precision medicine also to the patient. So there are many yeses to or ticks to these boxes on technology, and the next few years is definitely going to see a boom in the technology to help us in transport and managing our patients in the ER.
Thank you very much, Dr. Khusrav. With this, I think we are on track, on time. Thank you for all the panelists for joining here this session, starting from each one of you. And it was so relevant to speak about the patient safety, and it is coming from the mouth of the most important people who are managing the EDs for long, long time. And that's the way where we, as emergency physicians, think of not only about the patients, the quality and the quantity, what we see and how we manage and how we take care. So, on behalf of Society for Emergency Medicine India and COHO, it's a very important discussion which has been taking place. Thank you very much.
Thank you. Thank you, everyone.
Thank you.
Thank you, Srinath, sir, for that wonderful moderation. And thank you to all the panelists who had given your insights. It shows real expertise, what you are having, and trying to make our patients more safer on daily basis. Thank you so much. And dear